Hello, and thank you for joining the Donut of Destiny. This special episode is sponsored by GE Healthcare. References to a specific product, process, or service by speakers during this podcast do not constitute or imply an endorsement by the Society of Cardiovascular Computed Tomography. The views and opinions expressed do not necessarily reflect those of the Society of Cardiovascular Computed Tomography. Thank you for joining us.
GE Healthcare is glad to be the sponsor for this episode of the Donut of Destiny podcast. GE Healthcare is the leading global medical technology, pharmaceutical diagnostics, and digital solutions innovator dedicated to providing integrated solutions to make hospitals more efficient, clinicians more effective, therapies more precise, and patients healthier. Learn more on our CT solutions on the GE Healthcare website.
Hello, listeners, and welcome back to another episode of the Donut of Destiny, the podcast on all things cardiac CT for anyone interested in cardiovascular imaging. My name is Praveen Ranganath, and I'm a radiologist from Dallas, Texas. On today's episode, we will be exploring a new topic to the podcast, cardiac imaging in the pediatric patient population. Providing their expertise on this topic are two of my guests, who are pediatric cardiologists and cardiac imagers in the University of Chicago. My guests are Dr. Madhu Ganigara and Dr. Wasim Kausar. Madhu, Wasim, welcome onto the podcast, my friends.
Thank you for having us.
Thank you so much, Praveen. Thanks for having us on this podcast.
Excellent. Wasim, Madhu, thanks again. Before we jump into the conversation itself, I think that it's important for our audience members to know a little bit more about you and the context of where y'all are practicing. So could you speak to us about the roles that y'all have at the University of Chicago, how you both got into pediatric cardiac imaging, and perhaps what type of imaging practice y'all have at present? Wasim, why don't we start with you?
Sure. So I am a pediatric cardiologist, and my primary site is at Advocate Children's Hospital, and we have an affiliation or collaboration with the University of Chicago, where Madhu is primarily located. My practice is general pediatric cardiology with a focus on advanced imaging. I do cardiac MRI and CT, as well as other echo imaging modalities.
Awesome. Thanks, Wasim. And Madhu, what about you?
So me and Wasim are partners in this. We both do advanced cardiac imaging as in our hospitals. So I work at both the sites, Advocate Children's Hospital as well as the University of Chicago Medical Center in Chicago. It's a great time to be a cardiac imager. I feel there's so much innovation happening, and it's really exciting times. And I'm really happy to be working with some great group of people here, including Wasim.
Excellent. Once again, thank you both for coming on to the podcast. I think you will both provide a unique perspective that much of our audience may not be super familiar with, as many in the audience we have are predominantly adult cardiac imagers. As I'd mentioned, the topic at hand here is pediatric cardiac imaging, specifically pediatric cardiac CT. But we as imagers, of course, understand that importance of a multimodality approach to problem solving. So with that in mind, can y'all give me some ideas as to the complementary roles of CT and, say, echocardiography or other modalities in pediatric imaging? Wasim, why don't you start us off?
Sure. So CT, MRI, and echo are all, as you said, complementary, and we work together with our teams in order to determine what's the best imaging for any particular patient. And it is a very collaborative approach with the other imagers and surgeons and cath doctors in our system. But CT in particular is well suited for assessment of the vascular anatomy when it comes to congenital heart disease. So aortic arch anomalies and pulmonary artery anomalies and abnormalities of post-surgical problems that we see. And so that's where CT really shines in the pediatric patient. Intracardiac anatomy is generally better visualized on echo and MRI, although there are certainly scenarios where CT is used to clarify specific details. So it's often used in conjunction with MRI and echo.
Yeah, if I can chime in, I'd like to say that similar to the practice in the world of adult cardiology, transthoracic echocardiogram is still our workhorse imaging modality that we turn to for anything to do with cardiac imaging, both in children and adults with congenital heart disease. But as Wasim will attest, that with advances in the imaging technology, we are seeing that more and more of these requests for CT and cardiac MRI are coming through to us. And certainly over the last 5 years or so, we've seen that the practice of congenital cardiology has changed, that more and more requests for these are coming through. And where previously we might have performed a cardiac catheterization, more and more we are doing a cardiac CT now. This is because with pretty low radiation doses, we can get excellent anatomic imaging. As Wasim said, there are specific indications where CT is most helpful. And in 2020, the American College of Cardiology came out with its first appropriate use criteria for multimodality imaging in patients with congenital heart disease. And this has, in a way, helped to standardize clinical practice across various centers.
Yeah, I'll add in there, as you mentioned, with the use of cardiac cath and where CT is excelling is we've essentially replaced diagnostic cardiac cath with CT. We almost never in our center do a pure diagnostic cardiac cath for anatomic assessment. Diagnostic caths are now primarily relegated to hemodynamic assessments, and interventional cardiac caths. So the vast majority of the caths that our team does now are looking at hemodynamics, like in pulmonary hypertension, or doing interventions. And almost all of the diagnostic anatomic assessment is done by CT or MRI. Yeah.
So, Wasim and Madhu, from the adult perspective, oftentimes what happens for us imagers is that the request will already be processed and images already be performed by the time it shows up on my work list and I start interfacing with the images and therefore the team. Is the same true in the world of pediatric cardiology, where our referents are very familiar with the pros and cons, the advantages and disadvantages of each modality, or is there a more linked relationship that y'all have with the referents, the surgeons, the other cardiologists, or general pediatric medicine practitioners in the hospital?
I'd say it's almost the opposite as what you would see in the adult world, where there are certain scenarios where certainly our partners and other pediatric cardiologists will know that CT is going to be the best imaging modality, right? If you have a patient where you suspect a vascular ring, they just order the cardiac CT, right? Most other cases, there's either a discussion beforehand in trying to determine what type of imaging is needed, or at minimum, once the request comes through, the cardiologist that's going to be overseeing the CT reviews the chart, and we tend to make dedicated protocols for each patient because there's so much variability in what we see come through the scanner. It's difficult to have one standardized protocol for how to perform the CT. So we like to write up a dedicated protocol for each individual patient and work directly with the techs. Majority of the time, we're actually at the CT scanner overseeing the CT.
I do want to get into some of the protocol discussions a little later into our conversation, but before we get into the nitty-gritty of how the images are required, I want to discuss perhaps something that's quite common in the world of CT angiography, which is iodinated contrast administration. So can you all speak to perhaps some specific challenges of using contrast in a pediatric population and how you both overcome these? Madhu, why don't we start with you?
Yeah, like with the adults, the good quality cardiac CT in children requires the ability for us to inject the intravenous contrast agent at a fast enough rate. But we have to take certain precautions in children. Generally, we do not perform renal function testing prior to these cardiac CT scans unless we know or suspect that there could be pre-existing kidney disease. The other question is with regards to the injection rate. We are somewhat limited because children, we cannot have these large bore peripheral venous catheters, and so the workaround we have is we routinely use now the BD Diffusix catheter. This is a special catheter that has side holes in it, and it allows for high rate and high pressure of contrast injection, allowing us to inject and get good contrast opacification. These catheters come in different sizes, starting from the 24 gauge catheter that can be inserted even in a neonate as small as 2.5 kilograms. And this 24 gauge catheter actually allows us to inject at a rate of 3 ml per second and pressure as high as 325 psi. So this really helps us overcome that limitation. In terms of the site, we do not specify, and we in smaller infants and neonates, we take whatever limb they can give us, in be it lower limb or upper extremity. And for the older children, we ask preferably the antecubital fossa, similar to the adult cardiology. Sometimes there are situations where we are unable to have the diffuse catheter placed, and this is usually in an infant who's been a chronic long-termer in the ICU, and so all of their peripheral venous accesses have been burnt. And so then we sometimes have to do with whatever they give us, and we sometimes hand inject and try to guess the right time to trigger the scan. Rarely we come across some infants who have a power injection capable central venous catheters, and so we use them when they are available. Now, coming to the contrast agent, we use a low osmolar agent such as Omnipec. We use a dose of about 1 to 2 ml per kilogram body weight. In some of the smaller infants, we dilute the agent to 70 or even 80% strength. And what this allows us is to do is we can inject a larger volume over a longer time, but also it helps us avoid the beam hardening artifact that we sometimes see because of contrast, dense contrast in the SVC. So that's an advantage in some of the smaller infants. And lastly, I will say that with the modern CT scanning technology, we are able to get away with even low volume of contrast in someone who we may be worried about renal function. Even with a lower dose of 1 ml per kilo, say, we can get pretty good contrast injection in some of these children.
So, Madhu, I got a couple of quick follow-up questions for you. You had mentioned that for your diffuse catheters and your both neonates and infants, you are power injecting these catheters. I presume then that you're using some form of either bolus tracking or absolute timing to capture pictures. Is that correct?
Correct. We do not do any pre-scanning to identify the right time to inject. We bolus track. We place our region of interest in either the descending aorta or the main pulmonary artery, depending upon what the area of interest is. And we then guesstimate a time based on the flow rate, patient size, the heart rate, and so on.
In the neonatal population, I know that there's oftentimes umbilical venous and umbilical arterial catheters that are placed. Are these ever used for contrast administration, or are they typically avoided?
The umbilical venous catheter, if we have no other option, we can hand inject. We would almost never power inject through them because of the risk of injury to the catheter, the surrounding vascular structures, but we hand inject on occasion.
I'll add in generally speaking, the umbilical catheters, because of the length and the bore of the catheter, it's really not amenable to contrast injection except as a last resort. They're really high resistance. Oftentimes I'll do the hand injection myself because the nurses don't feel comfortable pushing as hard as needed to get the contrast in fast enough. And it's very difficult to get that contrast through those tiny catheters. So.
Got you. And for both of y'all, you had mentioned that it's primarily extremity diffuse catheters that you prefer for either power or hand injection. Occasionally, I'll notice in my neonatal ICU that there will just be, for example, scalps that we have peripheral IVs in. Are these amenable to at least hand injection for these type of exams when no other option is available?
Yeah, I'll use just about anything as a last resort, and the scalp would definitely qualify as a last resort. If you infiltrate the catheter in the scalp, you can cause some pretty bad scarring that could potentially even be permanent. So I try to avoid that as much as possible.
Excellent. I want to move now from the topic of how we inject contrast materials to how we capture those motion-free pictures. So from the adult world, the heart is moving and oftentimes the patients don't necessarily cooperate with breathing instructions. But I imagine this is even more challenging in our pediatric population where most of our patients may not even understand the breathing instructions, let alone be moving around and wiggling around on the scanner table. So could you talk about how you overcome some of those difficulties with bulk patient motion in addition to cardiac and respiratory motion?
Yeah, so there's kind of two or three aspects to this. One is the bulk motion, which I can start with, and that is really dependent on the patient's age and developmental readiness to listen to instructions. So, in a newborn or neonate up to around 2 months or so old, we can almost always just feed the baby and swaddle them really tight. And that puts them to sleep. And once those babies are asleep, generally speaking, they sleep deep enough that you can just throw them in the scanner and scan, and they don't move. Above 2 months old, it starts to get a little sketchy with that because they're a little bit more aware of the world and they tend to startle when we inject the contrast. So, depending on what the patient's status is, we may start transitioning to sedation and anesthesia. And that can range from a little bit of IV or oral Versed to general anesthesia. Generally speaking, in those kids, even when we do general anesthesia, we don't intubate. Most of the time, we'll either just do a medication, like an IV or mask induction. And then once they're asleep, throw them in the scanner. And the scan is generally quick enough that we can just scan them, take them out, and let them wake up. As the children get older, then there's a little bit more flexibility in doing the scan awake again. And that we kind of assess along with the cardiologist who's referring, the anesthesiologist who may be presiding, or the kind of child life team at the scanner, and see what the child is ready for. And once they're able to, if they can lay still for 10, 15 minutes, then I say that we can do the scan without sedation. Then up through the older patients, again, then it has to do with their developmental status. If it's a patient with a lot of developmental delays or severe anxiety or PTSD related to chronic hospitalizations, sometimes we elect for anesthesia even in those patients. So that's kind of the bulk motion as far as, is the patient actually going to lay still for the scan? The other side of it is respiratory motion. And in the past, I used to scan on a older 64 slice scanner. So it was all retrospective EKG gating. It was a long acquisition. And so respiratory motion was a big problem. And so if a patient couldn't hold their breath, at those times, they used to always intubate and do a breath hold. Nowadays, for patients getting sedation or anesthesia, I just let them breathe freely. The latest generation of scanners, we have a GE Revolution 256. The temporal resolution reconstructed is down to 70 milliseconds or so. And so the respiratory motion kind of becomes a non-factor most of the time. As we get older patients, sometimes the respiratory motion becomes a little bit of an issue. And so we really pressure them and coach them through the breath holds. But generally it's not too much of a problem. And the speed of the scanner is really our best friend on that. And the newer generation, the latest generation of scanners, the dual score scanners from from Siemens, and the newest GE Revolution that has a faster gantry rotation time, the temporal resolution is so excellent that respiratory motion kind of becomes a non-factor as well.
Awesome. One of the challenges I often run into, at least in the adult world, is on some of those older scanners that are available in some of our clinics outside of the main hospital centers, that they do deliver a pretty substantial dose of radiation to achieve similar or not even as good image quality. Could you all speak to perhaps the even more pronounced potential downsides of radiation dose and how we manage said radiation doses in the pediatric population?
Yeah, radiation is certainly a big challenge, and especially as you said, mentioned in some of the, I would say probably 5 years prior to now, that was a big concern that we were radiating these children a lot by using some of the older scanners, and the concern is especially higher in children who may require multiple scans over their lifetime. So especially those with complex congenital heart diseases. So from our side, the first step we kind of want to address is ask the question whether this patient really needs this study. Is this something indicated right now? And again, I will refer the listeners to the appropriate use criteria guideline that I mentioned earlier. And so we go through that discussion among the group with the provider about this question. And when we determine that the CT is necessary, there are certain CT techniques that we follow that helps us reduce the radiation dose. First among them is limiting the scan region to the anatomic area of interest, in our case, the chest and the heart. And so we try to center the heart in the isocenter of the gantry. We avoid any pre-contrast scouts. We bolus track, so we do not do any added radiation by doing that. We have predefined acquisition settings based on patient weight in our CT scanner, and that allows us to not need to change the scanner settings based on like the technician does not have to change things on the fly. Additionally, most scanners, including ours that we have, are able to optimize the tube potential and the tube current to the patient size based on the size that it determines in the scout images. In general, with most neonates and younger children, we use a tube potential of about 70 to 80 kilovolts and up to 100 kilovolts in older children. And as Wasim mentioned, we have a ultra wide detector G revolution scanner. So it has the advantage of having the longer Z axis coverage of up to 16 centimeter. And this allows us to do axial scans. And so we avoid some of the pitch related over scanning, overlap, and so on. And in neonates, we can get away with as little as 8 centimeter of the Z axis coverage. And in centers who have a dual source scanner, obviously the higher temporal resolution, which is as high as 66 milliseconds, I think, that allows for single beat scanning and reducing the radiation dose. The next big factor, how we try to limit the radiation, is by limiting the cardiac phases that we acquire when we get these scans. You had a podcast on systolic imaging in the past. So similarly, we try to limit the scan to the systolic phase acquisition in patients who have a high heart rate. Usually that means we are scanning at 40 to 45% of the cardiac cycle. Lastly, the newer iterative reconstruction algorithms. In GE, we have the ASIR, and in Siemens, they call it the Sapphire. This also allows for significant reductions in patient radiation dose. So what it comes down to is in most of our scans, we can get away with the total radiation dose per scan of less than 1 millisievert of radiation. So this amounts to about less than 10 chest X-rays. And so considering the amount of information we get and say we are avoiding a cardiac catheterization, I think it's a pretty good deal. And a lot of this has to do, as I said, with the newer scan technologies.
I'll add in that in many of our patients, definitely less than 1 millisievert, and in many of our patients, it's around the quarter to half millisievert. If we have a appropriate heart rate and scan coverage area, we can really narrow it down. And Madhu and I have recently also have started looking through, and we've learned that over time that we were actually overscanning many of our patients. We acquire either systole or diastole based on their heart rate and question of interest. And we may be scanning from like the 35 to 55% range in systole. And we almost always are only looking at the 45 or 50% phase because that's the one that's best. So we've started cutting that down further and narrowing our gating range, which has reduced our radiation doses further without really any loss of image information.
Wasim and Madhu, that's super impressive in terms of being able to adequately answer the clinical question at hand with tremendously low radiation doses. Beyond just radiation dose, each of the topics we've touched on, you've both mentioned that there's quite a variety, quite a heterogeneity in types of patients that come to you both. Of course, they're the pediatric patient population, but they come in all different sizes and ages. This certainly, I imagine, poses challenges for the imaging department to deal with, less than 10-pound neonates versus potentially nearly adult adolescents. Could you speak perhaps to the general principles behind accommodating for the variety of different sizes and ages of patients?
Yeah, it's all about preparation. And so we review every case before the patient gets on the scanner. The way we've kind of developed our workflow as far as what works for us in our center is whoever is going to be scanning a particular patient on the given day reviews the case the day before or the morning of, and we actually type up a protocol and send it out. And so that when we get to the scanner, we have everything planned to optimize the images for that particular patient. And that is everything from the contrast dose and infusion rate and contrast timing to coverage and gating settings.
I do want to jump into a bit more fine detail about a few image acquisition protocols that many of our listeners have, at least peripherally or maybe on a daily basis, get involved in the post-surgical anatomy realm for adult or pediatric congenital heart disease. Those would be pre and post repair single ventricle physiology patients, as well as those with repaired tetralogy of Fallot. Could y'all walk through perhaps an example case for each of those and talk through, maybe generally speaking, how you would try to image both of those by CT?
Yeah, I can start off by talking. So, in general, when we talk about protocols in the congenital world, we can probably divide this into biventricular anatomy and single ventricular anatomy. And I only say this because in Fontan patients, the protocol has to be pretty much tailored to the patient. So, I'll talk about the biventricular anatomy patient. So here the question then comes, are you interested in looking at the left heart primarily, or is the question about the right heart, such as in a patient who has had a repaired tetralogy and now comes with severe pulmonary insufficiency, and so the interventionalists want to see how the RV outflow looks, how is the branch pulmonary arteries, in which case we want the contrast to be more in the right side of the heart to look at the anatomy area of interest. So we use in cases of these biventricular anatomy patients, we typically use a biphasic injection protocol, where what I mean by that is we use neat contrast followed by flush injection. And we use a dose of 1 to 2 ml per kilogram body weight. And depending on patient size, we inject at a rate of for neonates, we would go as low as 1 ml per second. And in some of our older children, we can go up to 4 to 5 ml per second. And we then do bolus tracking. We place our region of interest. If it is the left heart that we're interested in, similar to your coronary protocols, we place the region of interest in the ascending or descending aorta. And if it's the right heart that we're interested, we place the region of interest in the main pulmonary artery or the RV outflow tract, which is easier to identify in some patients on the scout images. And once we see the contrast opacifying the region of interest, we set a predefined diagnostic delay, which is a term used in our GE scanners. And depending on the heart rate, depending upon the total amount of contrast we inject, it typically is in the range of 7 to 9 seconds. And we then acquire our images, and we've had a good result with this type of protocol. I will let Wasim answer the question of how we protocol our single ventricle patients.
Yeah, so the single ventricle patient is a whole other bag of worms, and trying to adequately image the Fontan conduit by CT is a problem that many people have tried to tackle over the years in many different ways. And to be frankly honest, it's one of my least favorite things to try and do because it's often an unsatisfying process. But there are a variety of approaches, and so the hardest problem is getting contrast where you need it, when you need it there, and to fully fill the structure that you're trying to see, right? So in a normal heart, you're injecting your contrast, it's coming through the right heart, it's mixing with the blood and then ejecting out to the pulmonary arteries, and you have this contrast diffusely mixed within the blood as it comes through the left heart to see the structures of interest. In a Fontan patient, the blood flow just doesn't go that way. You have lots and lots of streaming artifacts at every stage of the flow. As you inject contrast, if you're injecting in the upper extremity, you have laminar flow down the SVC of one arm has contrast, the other arm has no contrast. Those two parallel streams of flow are not going to mix with each other as they enter the pulmonary arteries. And so the contrast generally will prefer one side or the other, and the low contrast flow from the lower body and the other arm is generally going to prefer the other pulmonary arteries. So as contrast, you get a first pass of contrast through the pulmonary arteries. It's very typical to get an appearance of a pulmonary embolism where you have segments of lung that don't have any contrast. So this is a problem we encounter all the time from patients who came through emergency rooms or elsewhere, other hospitals where they did a PE protocol CT in a Fontan patient with shortness of breath or chest pain. And they get read as a pulmonary embolism because there's a segment of lung that has no contrast, but is really just streaming artifacts. So in order to get around that, the only way is to wait for the second pass of contrast, where the contrast has circulated through the body and is now coming back through all the veins, all the systemic veins, through the SVC and the IVC all at the same time. Even that gets tricky because you never know how long it's going to take for that contrast to go from the SVC through the heart, out to the body, back through the IVC, and up into the Fontan conduit. Generally, it's somewhere between 60 and 90 seconds is going to be the optimal time. But by that point, much of the contrast has been filtered out by the kidneys. It's been diluted with the patient's entire blood volume. And so you don't get a really tight, beautiful contrast bolus coming through the Fontan. There's a couple of ways that people have tried to get around that. One is to inject the lower extremity. But I have found in my experience, while it's been reported in the literature as a successful technique, I have found it to be mostly unsatisfactory because you still have streaming artifact from the other leg and the renal veins and the hepatic veins, which all have no contrast as that contrast is coming up the Fontan. So most people have kind of abandoned that dual injection upper lower extremity approach. It's technically difficult. The timing is hard to get right. And even then you still get streaming artifacts. So the way most of us get around it is we give an absolute boatload of contrast for the first pass. So anywhere from 120 to 150, some centers I've heard even go up to 180 cc's of contrast for an adult size patient. So we give a very large volume of contrast so that by the time of high osmolarity contrast, by the time it comes back through the systemic veins, there's still enough density that we can see the Fontan conduit well. And then we do the same kind of image acquisition protocol gated CT that we would for a first pass, only we do it at that 80-second delayed phase, generally speaking. And then in order to, depending on what the question is, if there's also a question about intracardiac anatomy or the aortic arch, then we'll do it as a two-phase acquisition where we inject, we acquire first pass of images through the aorta. So we get that tight contrast bolus coming through the aorta in a first phase. And then we acquire a delayed phase beyond that. Sometimes if where you have a patient with low cardiac output or other uncertainties, I may acquire two delayed phases, hoping that one of the two will be better than the other. And so that's generally how we get around it. Other options that we have used selectively is to give a slow infusion of a portion of the contrast first, followed at the end by a dense high rate bolus, so that we acquire that when that high density bolus is coming through the aorta and that lower density or longer injection of a slower rate has already gone through the systemic venous phase. So you can capture everything in one phase. We've had variable success with that. The timing for that is still also challenging. And as you can imagine, any of these techniques where we're doing multiple acquisitions, it doubles or triples the radiation dose. So we use it kind of cautiously. And so it's a challenging process, but generally speaking, we have pretty good success with that, first phase and then 80-second delay acquisition. And in a teenager age patient. In younger patients, we adjust the dose and the timing. But
wow, I got to say from you both, that was a rapid masterclass, and what I suspect are some of the most challenging patients to image by CT. So appreciate it from both of y'all. To give perhaps some final context about the imaging protocols and the questions being asked in general, what is the most common question that comes to both of y'all in the CT perspective? I presume it's not post-surgical anatomy, but I'm curious to hear from you both on it.
It's a pretty wide variety. I'd say the most common indications we get for congenital cardiac CTs is aortic arch anomalies and vascular rings, post-surgical and sometimes pre-surgical pulmonary anatomy for patients with pulmonary artery stenoses or hypoplastic pulmonary arteries, patients who have had previous interventions on the pulmonary arteries where you just can't see the distal vasculature by echo, and then anomalous coronary origins. Those would probably be the three most common indications that we get.
I agree. The post-surgical anatomy is also pretty common. Repair tetralogy evaluation is one of the most common indications we get. And there's a fair number of adult congenital heart disease patients that we get where the primary question is looking at the coronary anatomy. So we do that as well. Obviously, in these patients, some of whom are as old as 50 to 60 years, we tend to ask our adult colleagues to help us there to look at some of the adult world related coronary issues such as calcification, thrombus evaluation, or plaque evaluation. So we ask for help there.
Excellent. You both clearly have a tremendous amount of expertise in the realm of not just pediatric cardiac imaging, but pediatric cardiologic and cardiovascular medicine altogether. Therefore, I suspect that the majority of pediatric cardiac CT is performed at high-end centers like the ones y'all are both practicing at. This, I imagine, may impact patient access to care, where children that are remote from large centers that perform pediatric cardiac imaging may have some challenges in getting this super high level of pediatric cardiac CT. Could you speak to some of these challenges and perhaps ways in which we can try to overcome them?
I have a couple thoughts on that. One is that the unfortunate reality is that it does take quite a bit of expertise to have the staff and reviewing cardiologists or radiologists who really know what they're doing to get optimized imaging. As time goes on and the technology advances, there are more opportunities for getting these patients access to what they need at the smaller hospitals, further, that are not major institutions. Because if in theory, if another hospital has the high-end scanners that are capable of scanning these patients, the protocols are relatively straightforward if the tech knows where all the buttons are that need to be pushed, right? So if I can talk to a technologist at another hospital, I can generally walk them through exactly what they need to set up and how they need to trigger the scan to acquire good quality images. And also, remote access to scanners and post-processing and everything is now the norm. So as long as we can get access to the data after it's acquired, it's easy enough for us to review. That takes a lot of logistical setup in advance, but I think that it's definitely something that is coming with time. And I know some manufacturers have even started making their scanners capable of being operated remotely. And so that's another potential opportunity for improving access in these smaller, more remote regions.
Thanks, Wasim. Madhu, any thoughts on this?
No, I completely concur with what Wasim had to say. It is the unfortunate reality at this point, but as I attend more and more of the meetings, I see that more and more people are getting excited and interested in the cardiac CT. And with the recent change in the chest pain guidelines, where cardiac CT has been promoted as the modality for evaluation, that has the interest from the adult world has trickled down into the pediatric congenital world. So we are seeing more and more trainees interested in learning about cardiac CT and cardiac MRI. And so I see that with increased interest from the surgeons and the cardiac programs, more trainees are coming through. And I think in the next few years, we will continue to increase the availability of the CT technology to smaller hospitals as well.
Yeah, and a side benefit of the new chest pain guidelines are a lot of hospitals that previously weren't doing a lot of cardiac CT in adults are now installing latest generation scanners that are the same ones that we use to get good pediatric images. And so the technology is there. And so from a pediatric cardiologist standpoint, it's now on us to try and kind of utilize that to our benefit.
Yeah, I love that. The rising tide of awareness of cardiac CT and its benefits in cardiovascular medicine altogether is lifting the boats on both the adult and the pediatric worlds. I dig it. I do want to now talk about some of those exciting future developments, things that are on the cutting edge or just around the corner that y'all are familiar with in the pediatric cardiac CT realm that you'd like to share with some of our listeners.
Yeah, no, I'd like to take this. I love this question. Thank you.
Yeah. This is Madhu's pet projects.
Yeah, go for it, Madhu.
So a lot of exciting things happening, especially in the realm of virtual use of virtual reality and 3D printing, where we are able to segment out this 3D data that we obtain usually from a CT, but also sometimes from MRI images. And these are already being utilized in various other areas of medicine, including dentistry and orthopedics. It is a rapidly growing field. But lately, these technologies are now creeping into the cardiology world as well. And congenital heart disease, especially, lends itself very uniquely to the use of this technology. So, at our cardiac meetings, the SCMR and the SCCT meetings, I see dedicated sessions to talk about the 3D modeling and 3D printing. And we also have a dedicated WhatsApp group where there are nearly 150 members across the world who discuss ideas and throw out newer ways to do things. So really exciting time. In general, for actual real world use, I will say that the use of virtual reality environments and 3D print models allows for a couple of things. One is with regards to education. So this could include patient or family education, where patients can really understand what they have and what kind of procedure is going to happen, but also with regards to resident training, so they can understand the anatomy better. There are some models, 3D print models, that allow for surgeons to practice their skills. And with the VR headsets, the surgeons really love it when they can visualize some complex anatomy, such as a double outlet right ventricle where the VSDs are remote. They can then visualize better than seeing these 3D data on a 2D monitor. So they can prepare better for their procedures. Lastly, the other indication is where it allows for precision medicine, I think. So we are now able to perform virtual device implants. We recently had a complex adult congenital heart disease with failing fontan, where we helped them perform this, the transplant surgeons perform a virtual heart transplant. And that really helped them with some of the complex venous baffles that they had to do on this patient. There are so many papers coming out about virtual VAD implants and so on. So overall, I think more and more centers are setting up dedicated 3D print and virtual reality labs to help visualize this anatomy better. And I believe it is coming in the adult world as well, where they are doing virtual towers and so on. But in the congenital world, it's really exciting. Thank you.
Madhu, this is fascinating. I just wanted to ask one additional quick question about the virtual transplantation. Was this in the virtual space, i.e., in software, or was this a 3D printed virtual transplantation?
No, it was in the virtual software. So what we did was we used hearts, normal hearts from other patients of similar size, as well as a slightly larger size, and we tried to see how well that heart would fit in the patient's chest. And then we tried to look at, because this patient had a heterotaxy syndrome with dextrocardia, so the donor heart would have levocardia with normally placed IVC and SVC. So
amazing.
Had to mentally visualize how a venous baffle would look. And so doing this virtually and showing it to them, and where they gave their input on how they would do it, I think helped them plan better. And the patient did really well. And the surgeons were very appreciative of us doing that.
Mother, that is absolutely fascinating. Amazing, really cool stuff. I feel like the three of us could keep talking about this for several hours further. However, I do feel that we should bring this conversation to a close. Are there any final thoughts you have before we close the convo?
The only other thought I have as far as the future directions is the photon counting CT and the potential there for pediatric and congenital patients. improved spatial temporal resolution and reduced radiation dose of the photon counting CT is really exciting for me. We naturally don't have one yet, but in the small patients, that higher spatial resolution really could make a really huge difference, as well as reducing radiation dose that we worry about a lot in young kids that are going to get a lot of radiation in their life as it is. So.
Excellent. Great concluding thoughts, Wasim. Thank you both again for joining us on the podcast. I think this was a topic that we've been really longing to have discussions on, and the expertise you both provide is phenomenal. Thank you not only from me and from the SCCT, but the whole Cardiac CT Society for the work that you're doing for our patients and for the science itself. So Madhu, Wasim, thank you.
Thank you so much for having us. It's been great.
Thank you.
Of course, of course. To our listeners out there, thank you as always for tuning into the podcast. If you like content like this, please rate, review, and subscribe to us. That helps others out there find content like this. Once again, this is the Donut of Destiny. Cheers.